I guess I should unmute.
Hello.
Hello. So many familiar faces.
Has it been a year already?
Apparently it has.
It's been
A
more than
COVID
that.
year.
Yeah.
It's hard to believe how fast it went by. 15 months ago, when this group started, I missed the first meeting because I was on a cruise on the North Atlantic at the time. Doesn't that sound like it would be fun now?
Yes. Absolutely.
Maybe after vaccinations.
Right.
Right. Fair point, Vicki. Well, I know that I am going to continue to be as involved as in this work as the legislature and advocates will let me be. So I don't think this is the last time any of us will see each other. But I'm excited.
I hope not, Bevan. I look forward to seeing you some more.
Yeah. I'm honestly excited. I know this is really a horribly challenging year for so many people and a really incredibly challenging time for our world and our country and our state. And I also the opportunity here for Washington State to kind of lead the way, as I think we have in so many respects. And I'm honestly humbled to have been a part of this group, and I'm really excited to see however many of us want to continue to do this together in the coming years. To see what we can come up with that will be lasting and sustainable. And so I'm just want to say a big thank you to everybody.
Well,
Beth, I have to tell you. Oh, do you want to go ahead, Sherry?
Just for a sec. I've been in this for over 35 years.
Oh, just worked. Hello.
And I don't see myself as giving up anytime soon, although I sure am getting older.
That's in the eye of the beholder.
We're all getting older.
It's also in the feelings in my back. But anyway.
Bevan, I just want to tell you, I think you were spot on when you talked about state administered plan. I made that in my comments that anything having to do with our insurance companies right now really weighs on my trust level.
You catch that?
But, I think we should all remember, we started this process learning about other countries, Germany, et cetera, that uses an external market that's tightly regulated. They have a very limited role to achieve it. And if anyone here really thinks our state could assemble the whole shebang, when you hear what happens whenever you go on hold with a state agency, I'd love to take that offline. We just need to regulate the costs and drive out the profit and use a nonprofit. So I just don't see how to communicate that creatively. And that's clearly the public is not asking. They just want care, they want access, and they want quality and timely care. And there are many vocal people that, want to see a Medicare for all. And I mean, I don't object to that, but that's where I see unfeasibility. And if the state were to administer this, write the terms, write the contract, and let people compete, and they'd have massive enrollment to keep costs down with their managed care principles, it seems like the feasibility path in the middle of things.
Well, you have to be really careful and look at some of the lessons from other countries. The biggest one is if you underfund your single payer system, it does not work well. And that addresses your concern, Rich, that if we don't fund an adequate bureaucracy at the state level to run the plan, then it won't run well. For the same reason that you go on hold forever to the IRS. The IRS has been underfunded and they've had to lay off people. So guess what? They don't have people to answer the phones. So, and the same thing happens if you try to call Medicare. Where is that buzz coming from?
I'm sorry, that's my text message. I had to switch to my phone because I don't know if I can turn it off.
Right.
Apparently there's a consultation I'm missing.
Okay. There's also a huge difference between our quote nonprofit health insurers and German sickness funds. Our nonprofits are ballooned with so many people that they're investing billions of dollars because they don't know what to do with them since they're not allowed to have profits, and spending huge amounts of money on executive salaries. So we would have a major reform needed of the insurers in order to get anywhere near what Germany has. I'm not sure how many of them would be interested. They might say, bye, we'll go rip off people in other states.
I've been dealing with bureaucracies for 60 years in my insurance agency and neighborhood health. And I have a suspicion of all bureaucracies. And I guess that's the biggest problem I have with A. And my experience with bureaucracies, they all start out small. They all start out getting bigger. They all start out doing the job. And then all of a sudden, everything goes bad. And I really think we need a system that has a lot of alternatives. And what Rich is talking about is you really need competition, and you need to build it in there. I understand what everybody is talking about, being able to get good coverage immediately and not have to worry about buying it and all that stuff. But you really, really need to take it slow. And I don't think we should put our eggs in one basket. And I see the harm in A is it could be really good, it could be really bad. And it really needs to be a system that has lots of alternatives, lots of competition. And in fact, if you look at Medicare today, you see all the advertisements of all the companies offering different alternatives. All of a sudden, coverages are being expanded. And we need to think of that when we're going through all this.
But I think we also need to think about representation. When we say we need as much access and as much options as possible, we're still giving discounts to large organizations and people that have representation, and we're not giving discounts to people that have small businesses, and we're not giving. And why would we allow that? Why when you go buy a car, the salesperson asks you how much you make to make sure you can pay the loan or how you want to pay the loan. They don't ask you how much you make in order to tell you what the price of the car is going to be, right? The price is the price is the price. So until we deal with the price issues and why do some people get one price versus another, and what does how much money I make at my job have to do with how much I pay for healthcare? It has nothing to do with it. It masks the real problem, which is basically they're able to charge whatever they want because you're making life and death decisions, really, in most situations. And so unless it's a major thing like blood pressure, and we've somehow managed to get that down to a good cost, you're up against an entire system with no representation and no ability to even negotiate the price. So getting more selection and more offer, yeah, I can go look at 10 companies, but they're all pretty much going to offer the same pricing because they've all decided together that they're going to be competitive, and the competitiveness is here because they don't have to take in consideration that you are making a life and death situation or decision. And they don't have to take into consideration that you have no representation, like a Microsoft making a negotiation on your behalf. So until you deal with that issue and take out, and maybe it's a one price for all, you get to set the price of your product, but it's one price, and every single person gets that price regardless of how much money they make. Now, how that gets paid for, there should be other options, but let's not mask the underlying problem, which is we're trying to shift without knowing where all the shifting is going. The cost of paying for things is hiding the fact that people have representation and some people don't have representation. And we've taken the negotiation power away from people.
I think from the analogy of, let's say, our drinking water, right? It's provided to us by a public service. Every human being needs to drink water. We know that the public service is there. The competition comes in, the area around how do you make the water cleaner, right? There's private companies that have created all kinds of different technologies in terms of filtration systems and all of those aspects. But at the end of the day, the end product gets to the consumer in a way that we all know what the price is. We all know that it is something that we need to exist, to live. And I think that healthcare, for some reason in our country, has been so commodified. And when we have just to have the access to it, it's not, I think that the competition is beautiful, especially when it comes to different technologies and the education that goes into it and different practices, et cetera. I mean, I think that there's so many doctors in this group, you could all talk about different techniques, I'm sure, obviously over the years that have been used. And I think that is really healthy competition. And I think that helps drive the costs down. But at the end of the day, people need to be able to walk in and see that doctor and not have to worry about whether they're in the network or worry about, whether they're going to be stuck with a bill for their children to have to pay for them. So I think, returning to this kind of common understanding that, the education for our children, the water that we drink, there are certain aspects of public goods that I think that really, as a democratic society and as a developed nation, that we, I think, collectively have agreed are, public services. And beyond that, I absolutely agree with nurturing competition. I think that public-private partnerships are great. And I think that they should be continued to be put forward. I just think that, separating parts of our bodies, from our ears to our eyes to our mouth to the rest of our body, and then commodifying that access is really the component to me that is intrinsically problematic. And when you have companies that are literally built to answer to their shareholders, those efforts then become diametrically opposed, right? Because those shareholders want to see return on their investment in that company, and the company is only providing access, right? And that to me is where the rubber hits the road, and that's problematic.
What I'm talking about is administration. We have a single payer has one administrator, and I'm talking about having a product that's like water, but also having a variety of administrators delivering the product. And when you go to just one administrator, it can be really good, it can be really bad. And if it's really bad, it's going to be really hard to turn it around. And if you have competition, you have a vehicle to turn that around. And I agree with you, we need to take the profit out of the whole thing. When we do the administration, it shouldn't be a thing to make profit. And we should have mechanisms to share excess profit between the various companies that will want to administer it. In other words, if one company just happens to have a really good year, they should be sharing that profit with the other companies that have really a bad year. But it's the delivery system I'm talking about. And we really need variety when you do that. When you go to one, you're putting all your eggs in one basket. And that's just been my experience with bureaucracies.
But isn't this the dilemma that we're delivering to this confusion we're going to deliver to the legislature? Because really, if everyone could agree that this shouldn't be a for-profit entity delivered to the shareholders, and that the state can regulate all these things we're talking about in terms of costs and spread of charges among different kinds of providers and institutions, the state can do all that upstream and set the boundaries, the brackets, and then put it out to contract, and companies can compete for volume by extra things they can offer, et cetera, but they can't go below the bottom line. And that's what I'm just confused about, because that's not necessarily an A or B choice. That can be done, and it's nuanced. But we should not throw the baby out with the bathwater, because I'm on the provider side of this, and for all the bad things I hear of people being restricted from this medication or that test, sometimes it's a very good idea that their test was restricted, and we want to build the momentum towards rewarding for value-based care versus volume. And I just don't think the state can do that whole thing themselves. They need to use the power of competition, but tightly regulated competition. And if we use the language of just get the shareholder out of the equation, we'd be able to all get on board, I think, in this conversation.
So
Well-
I agree, Rich, that that it's really difficult to determine who's paying what and when, and that's our underlying problem, that the current system is based on not competing. There are hidden benefit managers in hospitals and in supply companies and certainly in pharmaceutical companies that I've had direct experience with. And it's not until we take the leap to really change that underlying and those hidden pieces. And I know, Rich, you've said it's overwhelming to even think about setting up an administrative or quality of care issue, but we're not in this alone. And there are other states that are fighting to do this, and there are some great examples out there that we've learned from other countries. Not perfect, but if we can pull in some of those those evidence-based techniques that we've utilized in several places in our state, in Washington State, and do it in a lot of different areas, this is an opportunity for us to really jump to an experiment that will pull in those administrative techniques that will give some incentive for real competition instead of actually stopping incentive. Like, insurance companies don't have an incentive to save money. The hidden layers of our system actually benefit when there's a higher charge for things because they get a penny on the dollar or something like that. So every dollar counts, every penny counts. So I think this is a rare opportunity for us to really step out and work with some other states, our state has a whole lot to offer. And if we can combine that with what's going on in other states, then I think we can make a difference. And, the argument that not everyone is going to come aboard is really dependent on the political will. Beth Johnson talked about large businesses being reluctant to give up the benefit that they can offer to attract employees. The real benefit people want and that workers deserve is more money. And in providing a health coverage through this current system that we have is a hidden benefit. It's a benefit to the company itself. They get, tax savings. It's a benefit to the hidden parts of our system. It's not a benefit for the employee, for the common person. So I think we really need to take some chances now. This is a rare opportunity. We have some waivers that are available through the Affordable Care Act that can allow us to really jump in full scale and use the work that's been going on in other states, the momentum that's building, and people want it. They know that there's better care available in other countries, that people are living longer, and we need to catch up. And this is a rare opportunity for us to roll in administrative costs, this talk about benefits. You know, who's really benefiting here? It's not the worker.
Well, I'd also like to point out, just to give a little personal example, I use a vaginal insert every 3 months for my ancient body part. And it's not available as a generic. It's only made as a brand name thing. I have to pay $150 copay every 3 months for it. That's a $50 copay times 3. And the cost, the actual cost of that entity, I've checked in Canada, and last time I checked was a few years ago. At that time, it was $100 Canadian to just buy it. I needed a prescription, but if I were just paying for it without insurance, it would cost me $100, which at that time, the exchange rate was such that it would have been $85 American for that. And instead, I'm paying $150. And where is that money going? It's going to some sort of a pharmacy benefit management through the federal Blue Cross Blue Shield program. And the pharmacy is being paid some astronomical fee on top of that, which they won't tell me what it is. And I've asked for their purchase of it from the company. And the whole thing is a ripoff, except I get a urinary tract infection if I stop using it. So so that is just an illustration. Talk about bureaucracy. This is what kind of bureaucracy we're dealing with. I'll take the state's bureaucracy any day over Blue Cross Blue Shield, pharmacy benefit manager, et cetera.
So let's hear from other people.
Yeah.
Vicki, you're muted.
Thank you. So I work with the Indian Health Delivery System, which is universal health care, but it's like drastically underfunded. So we do all these crazy things to make it work. But I think there is some importance to keeping the management a little more local. And I do agree that there needs to be some statewide infrastructure, but having the Indian Health Delivery System run by the federal government was a disaster. They didn't care. They didn't make payments on time. And as tribes have taken over their programs, we've been able to really provide better care and access to better specialty care for our tribal people. So I do think that that's important, that there's some kind of localized management of the benefits, just because you know, I know all the specialty providers from SQUIM to Seattle that our tribal members use, and I know how to get a hold of them and get them in there. And I think there's something to be said for that kind of access. And also, you know, as far as having the pharmacy benefit, or not the pharmacy, but a benefits manager, a TPA or administrator, or what have you, I think that I feel like that's better than, I know there's an idea that competition is good, but I don't think we need competition in healthcare. In the current system, whenever there's cuts, the people who have their benefits cut the most are really the people who can least afford it. You know, I've had benefits at work cut. I managed our benefits at work and had to cut the benefits for everybody and respond to them about that. But when we cut things for a group and everybody shoulders the same cut, that is different than having huge Medicaid cuts and taking away coverage for people and in your employer plan, getting your copay raised from $10 to $15. But I mean, that's just such a huge difference. But in a system where we can provide the same level of care for everyone, then everybody shoulders the same kind of cut. And I think that's a better system. And I don't think anybody disagrees with that.
Randy,
I
I
think
just,
he said for doing it at the state level first, which is of course what Canada did. They started it first in Saskatchewan in 1947 with hospital coverage for everybody, and then expanded it to physician coverage in 1961. And then the other provinces took a look over the border and said, hey, we like what's happening here. And they all started to do it. And Canada is still a whole bunch of provincial plans. They're all a little bit different, and they all have certain things that are missing and ways that it could be improved. But they are local, and then they have an overarching federal system that provides some money and perhaps some standards. I'm not sure how much in the way of standards, but there is something to be said for starting at the state level. Could we be the Saskatchewan of the United States?
And Dr. Weinberg, I wanted to tell you that in I think it was 2008, my tribe tried to start purchasing our prescription drugs. It was earlier, maybe 2005, from Canada, and the federal government threatened to cut off our funding if we did it because they didn't want us getting that good of a discount.
Oh, that tells you who they were listening to.
Right.
And it wasn't
Always.
the tribes.
Mm-mm.
Randy, I don't want to put you on the spot, but I feel like we've heard very little from labor in this, or at least I have heard very little from labor in our last year of deliberation. And just wondering if you have any thoughts or anything you want to voice or add, or.
You're in spirit.
If Randy took a coffee break, I'm in that same spirit. I'd love to. I see Dr. Dietering here. I wonder if she might be able to comment, because again, she's part of a massive organization of statewide penetration. They deliver very high quality of care. They are not beholden to stockholders. They need to cover their costs and make a little bit and pay their employees. But they focus on generics when it's appropriate. They develop protocols, evidence-based care, the right place, the right time. They check all those boxes. And there's, again, no shareholder in the equation. And so the idea of contracting through the state that takes in all the revenues with an entity like that needs to cover their costs. They need to, which is the dilemma we ran into with Cascade Care. But it seems to me that the principle, once you, I'm part of an FQHC along with Don, and I'll leave that out for a moment. But, Barb, these guys have the answer. They just need to be able to cover their costs and thrive. Barb.
Wow, that was a great introduction. I'm sorry I had to step away. We're planning on how we're going to give the COVID vaccine next week from Saturday. It's a lot of work right now. So I did kind of miss the first part of this breakout room. So I don't want to be off topic with what we're thinking about. I think the idea of large health systems that compete, where the goal is to take care of the population as a whole that you care for in the most cost-effective way possible, in California there are several of these kind of systems, from Sutter to Kaiser, and they do compete with each other, and it actually is a really good method. I think that the issue is that there are a lot of people, and this is going to be, that want to have absolute full choice between anybody that they want to see. They want full choice in which drugs they take, etc. And part of a system that is trying to control cost is also going to decrease some choice that people have in order to continue to control costs. And so one of the things that's come that I've heard in a lot of the conversation over the last few months is a concept that somehow you can kind of have it all. You can have universal coverage where everything gets covered, and there'd have to be a significant regulation if we're going to control costs within that world. And you can do it by having a centralized, very highly regulated and directed a set of rules about how you run the system and what's covered and what's not, and use individual pricing to try to help cover the cost. Or you could do, I like working with companies who are self-funded, and basically they cover the cost. You take a little bit off the top to run your business. And I think that has a lot of promise. The other thing that I want to be cautious about is I am not certain that the kind of cost savings that people believe would happen with a single payer is really likely to happen. It reminds me a lot of Brexit, where everybody thought getting out of the European Union, they would save all this money, but there's all these additional costs that happen. There's a different set of bureaucracy that happens when you go to a single payer system. It's not this panacea that you get rid of all these things that somehow are wasted cost in the system. It adds other kind of wasted costs, but and so I personally feel like I don't want what we recommend to sit on the shelf because legislators in this time and era cannot, I don't think, could be thinking far enough ahead to believe putting in a universal health system like choice A. I just feel like if that's what we come forward with, that's going to sit on a shelf and not go anywhere. Whereas if we can get C to happen, we all know these steps that we have been taken over the last decade are getting us closer to full coverage for everyone. And it's happening in a feasible way. And I think that's not a dirty word. And to be practical and think about what can we get done that continues us on our path to a single payer of some kind. It's not necessarily for coverage for Washingtonians.
I think it's more, what can we do immediately to prevent medical bankruptcy and getting people care? I think that has to be the first step, because it's going to take us so long to debate everything, but people are going bankrupt. It's $600 just for a regular annual